So urinary tract infections, I don't think I have much to say about that, apart from your question. And I'd still say that if you've got a man with a urinary tract infection, I think we should see them, to be honest. Unless he's got an obvious cause, he's having anal sex or something like that, then I think we ought to see them. And it's because they've got quite a high rate of having stones, hydronephrosis, etc., etc. Our pick-up rate's quite high for those, and we don't want to be missing bladder cancers, which is another cause for it. So I would suggest men with UTIs, it'd be good to send them up. Women, recurrent UTIs, a source of excitement in general practice? I bet you see some though, don't you? So have you had talks on strategies for that? Do you want me to quickly? You know all about it? No? Okay. So what do you do at the moment? Woman comes in, I'm having a UTI once a month. What am I going to do, doctor? It's driving me crazy. Okay, you could do an ultrasound, yeah. What do you think is most likely pathophysiology?
Make sure it is UTIs.
Yeah, well, we should definitely make sure it is UTIs. So let's say we send off we could do a dip, it's positive for nitrate, send it off, it's got some E. coli. We give some trimethoprim. How long are you going to give it for? 3 days, yeah. Give some trimethoprim. Comes back in a month, another UTI, E. coli again. Give some trimethoprim. Comes back in a month, another E. coli again. What's going on?
You need to check that it's cleared.
Those are mostly, I would suggest, relapsing UTIs. And I think it's quite right to give short courses of antibiotics, but I think we forget that I forget anyway, to say, have you got any pain in your kidneys, in your back? And I think it's amazing how often people will say, actually, do you know, I have got a slight twinge of pain in my back. And if you treat someone who's got the slightest bit of pyelonephritis with 3 days of antibiotics, it's a recipe for getting the infection back. That's the first thing. Another thing is, in that situation, I quite like nitrofurantoin. Any other nitrofurantoin fans in the audience today? Yeah, I like it, it's good. But I tell you what it's rubbish for. 2 things it's rubbish for. One is it's not any good for pyelonephritis. It's just got no activity in the kidney at all. So if your patient says, I've got some bit of back pain, don't choose it, choose something else. And then the other thing it's terrible for is prophylaxis. Not a good prophylactic antibiotic. Anybody know why? No, it's pulmonary fibrosis. Yeah, it's irreversible pulmonary fibrosis. We don't want to cause that in 35-year-old women. That'll be bad. So it's not good, that situation. Great antibiotic for a simple UTI, not any good for anything else.
What dose would you recommend? Is 50 strong enough?
Do you know, I never prescribe it. It's not something that I prescribe at the hospital normally. You know, you've seen those letters from us saying, we've identified that your patient had a UTI. Would you mind treating them?
I've seen those.
Yeah, I'm sorry about that. I'd like to apologise on behalf of the department. So mostly when I prescribe antibiotics, it's normally going to be prophylaxis, and then I don't prescribe it. So I tend to prescribe a round robin of, I shouldn't tell you that, should I? Because I'm going to ask you what it is. So that's one of the strategies, is to make sure the patient is properly treated. So you could do a post-treatment MSU, and I think that's a good idea in someone who's having repeated infections. I'd step up the length of treatment. How long do they need if they've got a renal element to their infection?
2 weeks.
So I'd say 2 weeks to be absolutely sure, yeah. Do you know what the mortality rate was for pyelonephritis before antibiotics? How many people died? Have a guess. 25%. 25% for a proper pyelonephritis. Sobering, really, isn't it? Okay, so that's one. Yeah.
For men, have we decided just one?
Just one?
One infection?
One, we'd like to see them. We might well send them back to you and say we found nothing. Sorry about that.
One document.
Yeah, I'd say so. The other things you could do for the women are, if they're postmenopausal, what might you try? Estrogens, yeah. If they're sexually active and the infection comes anything from day 1 to day 7 after intercourse, what might you try? Post-coital antibiotics. I got into trouble with that once in clinic actually, because I said to this lady, I said, if you want, you can take a prophylactic antibiotic. We'll give you 1 antibiotic a day, and just take that, and that'll keep you out of trouble. Alternatively, you could take an antibiotic after you have intercourse, and then you'll take less antibiotics. She said, I have sex 3 times a day. Crikey, how do you manage that? Anyway, there we are. So I won't tell you, maybe tell you afterwards. So post-coital antibiotics is another one, and another one. Sometimes people know they're getting a UTI, and they find that the strategy of drinking tons of fluid isn't enough. Some of those people get on very well with just-in-case antibiotics. But again, if they're prone to having infections which get renal involvement, and it's about your HLA subtype as to whether you're going to get that, then those people it's worth giving a longer course of just-in-case antibiotics. And then finally, we sometimes try prophylactic antibiotics, don't we? And then every 3 months you need to change the antibiotic and try and get round over the course of a year through a full set. Where it becomes really hard are people who've got multi-resistant organisms, and I think we all struggle then in secondary care and primary care.
Which one do you suggest the prophylactic?
As prophylactic antibiotics, I normally I try trimethoprim. I mean, in my letters I'll advise trimethoprim, cephalosporin, ciprofloxacin, amoxil, but not nitrofurantoin. And then it'll give the district pharmacist a heart attack, all of it, I've no doubt. But it's all at a very low dose. It's usually a quarter of the normal therapeutic dose.
But if MCU, if the culture specialist shows resistant to trimethoprim, do you still use trimethoprim?
No, I'd use whatever the sensitivity suggested.
No, because preventing it. Post-sex nutrition doesn't make any difference, does it?
It's a traditional thing to say, isn't it? But I don't think it does make any difference, no.
Is that the same, not the same for topical HRT? I thought that didn't.
Topical HRT, there are papers for and against. I mean, I think I still believe it's worth trying. HRT in general definitely doesn't work, but topical estrogen cream, I think it's worth a go. It seems to work for some people, but I think in meta-analyses and things, it's not a very strong effect and it's not statistically significant. I mean, I'm not very scientific about it, but I'm not a great believer in meta-analysis. Because I always think with meta-analysis, you take 20 studies, all of which are rubbish, with major structural problems, and you put them together and expect to get an answer. I think you just compound errors as much as find truth. So I still think it's worth, until somebody does a really big single study and says it definitely doesn't work, I'd still support the use of that. But I wouldn't do it endlessly, for years on end. Then if you still struggle, clearly we need to assess them at the hospital, and we need to make sure they haven't got anything else going on. Whether you decide you want to do some assessment in primary care is a bit up to you. Again, we've got a slight difference of opinion within urology, but what we would normally do when they come along for most of these patients is an ultrasound and KUB. You're welcome to do those in primary care if you want, ultrasound and X-ray. Make sure they haven't got an obvious stone. You can do that at any point in the process. But we would often also perform a flexible cystoscopy, which you clearly at the moment can't do in primary care. That's a choice. Yeah.
A while ago, the microbiologists, they stopped doing sensitivity against amoxicillin, and they just replaced that with cholinesterase.
Yeah.
And there's a little twist about that, because I think we could do without using cholinesterase where we can use amoxicillin. Do you have any input?
Well, I mean, as a non-microbiologist, I agree with you. It seems like a good drug to keep up your sleeve, and if amoxicillin works, it works. And certainly in prophylaxis, it would feel better. But if they were here to answer, I expect them to have 15 scientific papers to prove me wrong. So I can't speak with any great authority on that. It feels right, and I agree with you, superficially.
There's talk about doing a 3-month trial given amoxil sensitivities.
Well, thank you. There we are. So it looks like we're not alone.
People have thought about
which
it.
is nice. Is that all right for infections?
Just want to ask, if a patient has a UTI while on prophylactic antibiotics, do you just treat for the 3 days or 5 days?
Yeah, it's a really difficult situation. I think you should definitely do an MSU. You need to treat blind, don't you? But do an MSU and make sure that you get that infection sorted. So start them on something, get them back with the MSU results. If you've got them on an inappropriate antibiotic, treat them properly, and I treat them for a longer course, because by definition, these people having recurrent UTIs, they're not simple. I mean, if you look at their HLA subtype, often what it is that they've got a certain HLA subtype where the fimbri from the E. coli stick very avidly to the surface markers on their cells. So they're much more difficult to treat, and that's part of the problem. So they do need a longer course of antibiotics.